Hello, everybody. I hope everybody can hear me. I'm Dr. Hina Yousuf, and I welcome all of you on this forum. This is the 8th meeting of Society of Young Pediatric Urologists, and I'm pretty much overwhelmed to see that one of a very big name in pediatric urology, Mr. Tegul, is also with us. And this is really an honor for this forum. Mr. Tegul, good evening. Can you hear me?
Hi, Hina. Good evening. I'm sorry about my camera. I have a problem with the camera, but I'll join you with my voice. Is that okay?
Yes,
I'll see if I
absolutely.
can adjust it. I'll work on it.
Okay, sure. So, so in our participants, I can see there are many pediatric urologists, pediatric surgical residents, and urology residents. And today we are aiming to discuss three important cases. Two are from my institute and one is from Kidney Center. We're going to start in 1 minute. I'm making sure that the video recording also starts. All right, so there are three cases. First, I would request Dr. Zishan Zafar to present his case. Dr. Zishan, can you hear me?
Yes, I can hear you quite well. Thank you, Dr. Hina. Start with showing my screen. Um, okay, I hope my screen sharing is visible to everyone.
Yes, Dr. Zishan, we can hear you, but just you have to speak a little louder, and we can
All
see
right.
that.
All right. Is this okay?
Yes, absolutely. Better than.
Thank you, Dr. Hina. Shall I begin then? My name is Dr. Zishan. I'm a resident of urology in the Kidney Center. I was recently asked with Dr. Sharik, and in our OPD, we encountered a very interesting case, a rare case, and we felt like we just had to share this in this forum. So, to start with, our patient is an 11-year-old female born with a syndrome, having a congenitally absent left kidney and anorectal malformation, no in orifice, and a single urinary loop. Soon after birth, a laparotomy was done, a divergent colostomy was made. Her presentation in our OPD was the right solitary kidney with PCN in place, having equivalent discharge from the PCN. PCN was placed in Ahmedabad in February 2022. No history of fever, nausea, vomiting, or hematuria or dysuria was given at the time of presentation. And there was a single urogenital opening at the vulva. That was the presentation of the patient. We asked a prior history of LUTs, and we found that the patient had a prior history of continuous dribbling of urine with weak stream and intermittency, and that had been going on since birth. She had never really truly achieved continence after birth. In her past history, the surgical history was significant. Soon after birth, a laparotomy was done for divergent colostomy, as she had no natural anal orifice. Later on, many years afterwards, for reasons of lack of resources, patient had an anorectoplasty done in the January of 2022 in JPMC. During procedure, there was a cecal perforation for which an ileostomy was made, and a appendectomy and a hysterectomy was done as well. A PCN insertion was done later on.
Dr. Zishan, can you adjust your mic? Most of the people in the group cannot hear you properly. Dr. Sardar message is here. He cannot hear well. Can you please go a little slower and speak a little louder?
Of course, of course. Can you hear me now? Is that fine?
Yes, yes, it is fine.
This is better,
okay,
yeah.
In the past surgical history, I'll start again. In the past surgical history, soon after birth, a laparotomy was done for divergent colostomy, as she had no natural anal orifice. And then later on in 2022 January, an anorectoplasty was done in JPMC During the procedure, there was a cecal perforation, an appendectomy was done, and a hysterectomy was done as well. She developed obstructive uropathy in the solitary right kidney soon after the procedure, for which a PCN insertion was done in the right kidney in Ahmedabad in February. Her past medical history was unremarkable. We examined the patient and we found that the abdomen was soft and non-tender with no visceromegaly. Patient had a surgical scar in the lower midline, and a colostomy which was prolapsed was visible in the right lower abdomen. There was a PCN in the right flank. Her urogenital examination showed a vulva with a single pinhole meatus or urogenital opening, and the bladder was not palpable. We got some baseline labs done at the time, and her HB was 12.2 with a TLC of 11.8. Platelet count was 350, and a creatinine was normal at 1. Rest of the labs were also done, which were within normal limits. Her urine culture was positive for E. coli and was treated according to sensitivity, and the patient later had no fever or dysuria. Her renal scan was done in January 2022 prior to presenting to us, which showed an absent left kidney and a fair functioning right kidney. We also received an MRI scan in her document folder, which showed a solitary right kidney with a good cortex and a PCN in system. The pelvis showed a large distended cavity with communication with adjacent cavity. The cavities showed a mixed hyper and hypointense signal on T1 and T2 weighted images, representing blood and loss of varying ages. There was no clear delineation or discernible urinary bladder in the abdomen. At the time, we made a diagnosis which was consistent with Mayer-Rokitansky-Kuster-Hauser type 2 syndrome, which is a syndrome in which there is a Mullerian missing structures along with involvement of other organ systems. In this particular case, missing left kidney and also an underdeveloped bladder. Our management, well, initially we got an arthrostogram done, which showed a distal ureteric obstruction with no contrast going into the bladder. We planned and carried out a cystoscopy with an RGU and a right GJ stent insertion on the 10th of March 2022. Our findings during the cystoscopy showed a single urogenital opening with a narrow meatus, posteriorly extending into a rudimentary vagina and anteriorly extending into a small bladder with a capacity of only 10 ml. No urethral opening was visible at the time, though we did find a scar to be visible on the dome and the posterior wall, in which a small single opening was seen that proved to be the opening of the ureter. We were able to pass a DJ, but with considerable difficulty. So our purpose of presenting the case here is to discuss what are the future options available. Before we proceed further, we also invited our pediatric general surgeon to give her opinion, so that any future surgery which was done for the patient would be done in communication with in collaboration with the general surgery team, so that the patient would not require multiple surgeries. Also, it would be a difficult surgery as the patient has already had a laparotomy done once before. So what are our options? One option would be the augmentation cystoplasty with the Monty microphenoc and bladder neck closure. Another option would be an ideal conduit. And a third option would be to go for ureterostomy. I invite my panel for discussion. Thank you.
Okay, so right now, how old is your child? How old is your patient?
Our patient at the moment is hello, Doctor.
Zishan, how old is your patient?
Patient is 11 years old. Can you hear me? A patient is 11 years old.
Okay. So, Dr. Sharik, this is your patient. You're managing this patient. What are the thoughts of you on this case?
This case is a very difficult case because currently this is a syndromic child having only a solitary functioning kidney, and which is also compromised. The creatinine is currently 1.4, 1.5, and she basically this is a syndromic child, and she already had two operation done with having a complication in that surgery as well, as appendectomy and cecal perforation was done, and there was a colostomy prolapse also currently. This is also an issue. So the issue with us is that the bladder is very small. It's around 10 ml. We have to do something for the bladder so that it can be some kind of storage, or we can do anything for the future consideration. But currently she has only 10 ml bladder, and there is single opening. There is no vagina opening. The vagina and bladder usually have a single opening, and which was stenosed. I don't know how, but it was stenosed, and she came to us with obstructive uropathy in the middle as well. But currently the issue is that she had multiple surgery. We cannot go and do augmentation cystoplasty as appendix is already not available. There's previous surgery she went into sepsis, had abdominal exploration again, and have cecal perforation, and the condition of gut. If you go for augmentation cystoplasty, the condition of gut will not be as good as in case of a virgin case or any previous operated case. So what our consideration in this case is to do as much as possible for the child. So the issue is that augmentation cystoplasty will be very difficult in this case. So what we are considering is to do a ileal conduit, because currently, and because the bladder is very small, if we don't get any, because we have to get two large segment of small bowel for the augmentation and one for Monty Mitrofanov, and it will be very difficult for us and for the patient to have so much gut involved in the surgery, and the patient also have a prolapse of colostomy, and she also have to be dealt with by general surgeon, and they will also trim it as well. So there will be large amount of gut which will be lost. As considering that in mind, so we have a limited option. And
so the patient has a complex problem, not only a complex problem, the solutions are also very complex. So
yeah,
I can see a hand being raised by Dr. Mohammed Mas. Okay, Dr. Mas, can you please unmute your mic and...
Yeah, I'm Dr. Rashid. Sorry. This
Oh,
is my
Dr.
son's
Rashid.
name. Okay. Acha, one thing I want to ask to Dr. Sharik. What is the weight of this child? Can you please tell me?
The weight is around 25, 27 kg. Build is good now. We have rehabilitated the child. The weight is good now because the colostomy issue, she currently have previously have history of multiple diarrhea. Now we have rebuilt the child for around 6 months now. She have raised 25 kg, which is I think is very good for her. Previously, she came to us with around 14, 15 kg weight. Now that she have increased around 9-10 kg in the past 6 months. So our plan was to rebuild the child in 6 months, then have the surgery.
Okay. But the thing is that you are doing well because you have to first build the child, because all this prolapse and all these things could be due to the low weight and low when we will build the child, inshallah, we will see the good results after doing any surgery. So
Yes. Because the issue is that the general surgery issue should be dealt with in the same operation. She went to NICH and general surgeon have seen her, and they said the previous operation of the anorectal malformation, their anal pull through have failed, so they have to redo it again. So they cannot reverse the colostomy right now, and they have advised me that they will refreshen the colostomy, refreshen the anorectal pull through, and in that setting, we should do urological procedure, and that will be better as compared to that they will do colostomy reversal and then anorectal pull through in a single setting, because they're saying that to get 4 or 5 anastomosis in a single operation is better to deal with a single anastomosis one by one.
Okay, so if we summarize your case, Dr. Sharik, so your patient is a node syndromic patient. She is 11 years old and she is yet to have a surgery for her small capacity bladder with there's a solitary functioning kidney, and she has also a persistent urogenital case, so she would require vaginoplasty and she would require an anorectoplasty as well.
Yes.
Since she is malnourished, she need optimization of her status, medical status as well. I would like Dr. Sardate Gul to have show his express his opinion on this case.
Well, it looks like you need a diversion of the right kidney, and what seems possible is like an ileal conduit. I've not seen any antegrade X-rays because I want to see how dilated the ureter is. I understand that it's not much dilated, is it? The ureter is not dilated.
It's not that dilated. It's around mild hydronephrosis, hydroureter. It's not that dilated. There's no hydroureter.
I mean, one
You have-
option could be just cutaneostomy if the ureter is dilated. If not, you would do an ileal conduit. Since you're not able to construct a new augmented bladder, that would be the only option. Otherwise, one other option would be to create a pouch. There are different pouches that you can create. Like one I do is the Indiana pouch that I create from the right colon using the ileum as the continent stoma. That you can do and connect the ureter to the Indiana pouch. That's one option. Or ileal conduit will be a much easier and simpler option. Or as I told you, cutaneostomy could be an option if the ureter is enough dilated.
Yes, Dr. Tejgul, yeah, it's we are thinking of going for ileal conduit because the issue is currently, you are right, absolutely right. The issue is that because of the previous surgery have ileal perforation and patient have re-exploration because of abdominal abscess and because of that thing is more concern for me, because if I open the case and if I don't get enough amount of bowel for the Indiana pouch or any kind of pouch, it will be very difficult. That's why. What do you think in that case?
Yeah, I think ileal conduit would be a good option in that case. Yeah, I agree with that.
Thank you, Dr. Siddharth. Thank you.
All right, since we dedicate only 20 minutes for each case, I think, are there any more comments from the participants? Please raise your hand if there are any comments. So do you have any image of antegrade pyelogram in this case, Dr. Sharik?
No, basically we don't have we do it in an emergency. So currently it was done in another hospital. They sent me on a mobile that this patient had this issue and she's in an obstruction. So they sent the patient to me in an emergency. The antegrade nephrostogram was done in another hospital. That's why I didn't have it. And the patient is not from Karachi, he's from Ahmedabad. He took all his images back to his hometown. And when he came back in an emergency with the obstructive uropathy, he forgot everything. She just took her child and run to Karachi at my hospital. That's why we didn't have anything. Currently, they are in Karachi because currently there is a flood issue and everything. They cannot go back. And called for the images, everything, but we cannot do that. Also, we cannot make it happen. That's why. Otherwise, this will be a very good option.
Okay, so I believe this is a very sensitive case because you have to take everybody on board, like pediatric medical team, pediatric nephrologists, pediatric surgeons, and you yourself, and take everybody on board while managing this case. I wish you good luck for that.
Thank you.
All right, so now moving to next case, Dr. Akash from Liaquat National Hospital is going to present a case of a 10-month-old child with empty scrotum. Okay. Akash, can we see your screen?
Hello, Assalamu alaikum.
Walaikum assalam.
I will share my screen. Hello.
Akash, please start presenting. We can see the screen.
Yes. Heba, next, please.
So first, let me introduce you, Akash, to the group. Akash is a medical officer in the Department of Pediatric Urology and Pediatric Surgery, and he's, for the very first time, he's presenting on any forum. Akash, go ahead, please.
Okay. Thank you, ma'am. A 10-month-old male baby born with a subvaginal delivery at Trump. He presented with OPD with a complaint of bilateral impalpable testis since birth. In past history, the baby was born at Trump and he was admitted in an NICU setup for 2 days because baby was not past meconium and was admitted in a NICU setup for a conservative management. There was no history of abdominal distension and vomiting and diarrhea. And then again, patient was discharged from hospital and then again admitted in another periphery hospital for 3 days for a chest infection, which was treated with a IV antibiotic completely. Next. On examination, patient vitally stable, and on abdominal examination, the abdomen was soft and non-tender. There was no inguinal swelling, and patient was uncircumcised, and the patient has a small size of phallus. And the patient have a bilateral impalpable testis. Rest of the examination are unremarkable. Next. On workup, this abdominal X-ray show first day of life when baby not past meconium. There was show mildly small bowel dilated, and there were remarkable other findings was. And lab works would show on second day of life CBC, HP was 5.5, PCV was 44, C 3.7, platelet 431 and neutrophil 61, which was a normal, and CRP was 1.5, which is also normal. Next. And the ultrasound which was done on when patient was referred to OPD, the ultrasound was done which showed both scrotal sac not well developed. Both testes are present in the inguinal canal close to the bilateral inguinal ring, representing bilateral undescended testes. The right testis measure 1.3 into 0.4 centimeter and left testis measure 1.1 into 0.5 centimeter. And again, patient was again present in OPD. Then the other lab work was sent. The serum FSH was showed 1.58. The reference range is given. And the serum testosterone, which was shown normal, less than 2.5. And serum FSH is 0.15. And the blood chromosome was also done, which shows 46XY.
So basically, this case is a 10-month. Okay. Basically, this is a case of a 10-month-old child who was brought with history of underdeveloped scrotum, and the parents noticed that the both testes were never palpable in the scrotum, and it was seen by different pediatricians, and they asked parents to wait till 6 months of age, and after that he had one ultrasound where it was the report showed that there are no testes visualized on the scan. There was another scan that showed that there are no testes visualized in the inguinal canal, and we got a third ultrasound, and that showed because this child looks syndromic, he's very chubby, and he has microphallus, and the both testes were not palpable. So we started working him in the line of bilateral impalpable testes and did a hormonal workup, because mostly bilateral or cryptorchidism is associated with chromosomal abnormalities or with androgen insensitivity that we suspected in this case. So right now we haven't done HCG stimulation test so far, because for that patient is going to be followed up in next week. He has received the appointment for that day. But what should be the optimum line of management for this patient? So if I can ask Dr. Sharik if you can comment on this case, because usually bilateral impalpable testes are seen in patients with DSD, but here we have seen, there's microphallus and there's impalpable testes in this case. So how should it be managed?
Yes, Dr. Hina. Dr. Hina, what is your plan? What will you do? What is
Because
the current? What is the
current issue is, if you review the hormonal workup, Sharik, Dr. Akash, can you please slide up your presentation? Go to the slide of hormonal workup of this patient. Because if you see bilateral impalpable testes and you send hormonal workup, first you have to see the report of FSH. If FSH and LH is normal, then we look for the testosterone level. If you see the report of this patient, FSH is normal. It is not 3-time raised so that we think about anorexia or something related to problem with the volume of. So, but if you see the report of LH is quite low for his age. So can we understand how this discrepancy in the report is there? Why FSH is normal and LH is not normal? And testosterone is quite low.
Because I think there is some androgen partial insensitivity in this child, because I think that LH Leydig cells are not working. That's why the testosterone is FSH is there, but LH is not that raised. What you can do, you can take a pediatric endocrinologist on board, but you have to do orchidopexy after counseling the patient, the parents as well, because there is no other choice you have, and patient may need some testosterone replacement or testosterone ointments in the future. But it's better you should do beta HCG test in this patient to get some idea of whether the testing will work.
Yes, my plan is to go ahead with HCG stimulation test, but when this result came, I was a little. This result made me a little confused why FSH is normal and LH is below normal, and testosterone is also below normal. So one of the participants in this meeting, Zehra Kazmi, asked, what about 17-hydroxyprogesterone level? Dr. Zehra, we haven't got that yet. So Dr. Sardar, what is your opinion on this report, which is there on the screen?
I'm not sure if this is non-palpable testes, because in one report it was shown, and actually the dimensions of the testicles are given. So basically, the testicles are, as far as I understand, are in the upper end of the inguinal canal. And
yes, according to the report.
Yeah, and I see that there's good testosterone production. So there's functional tissue. I would consult with endocrinologists and get their opinion at this point. But we would normally try an LHRH or some sort of a testosterone stimulation, either with LHRH or just ACG, and see how the test is responding to that. The testicular size may increase and also some descent may take place, but eventually we will have to do surgery bilateral.
Okay, should we go for open exploration or laparoscopic?
Well, it depends on how you feel it. I mean, if you feel it really in the inguinal canal and you think it's reachable by inguinal exploration, I would do inguinal exploration. If not, I would start with laparoscopy.
Okay, He's 10-month-old, he's very chubby, he's 11 kilograms and a lot of fat in the subcutaneous fat in the inguinal region. So probably laparoscopic would be best in this child. But surely I'll take endocrinologist on board and take their opinion as well. Are there any comments from the participants? Dr. Naveed Harun, what is your, Dr. Naveed Harun is one of a very good fellow and he's a pediatric urologist. Dr. Naveed, if you can hear me, can I take your opinion on that case?
Well, thank you so much. What I would say is that we don't have an exegesis stimulation test over here. I mean, some of the laboratories over here cannot perform these tests. So what we do is that we try testosterone, give them testosterone. If the testosterone works and the phallus size increases, then obviously it doesn't have any element of androgen insensitivity. So in that case, we take it as I mean, if the testosterone increases the size, then it's okay. And then we go ahead with the surgery.
Okay, all right. So we
Dr.
have
Hina, one way or another, we have to do the orchidopexy. Either you do
Yes.
this or that. Orchidopexy should be done.
Okay. All right. Thank you very much for all the suggestions. And I think if we can, if there's any other comment from the participant, then I can welcome that. Otherwise, we can move on to the next case. Okay. So the next case is by Dr. Hiba. Dr. Hiba is a medical officer in the Department of Pediatric Surgery. Hiba, you can proceed with your case. Thank you. Thank you, Akash. Thank you for your presentation.
Yes. Hello, Assalamualaikum.
Walaikum assalam, Hiba.
So
Can I see your screen, please?
Yes, ma'am.
Hiba, I welcome you here because this is the very first time you're presenting.
Oh, yeah, thank you, ma'am. Okay, so here I present a case of a 3-year-old boy who presented in our urology OPD with the history of bilateral ureterostomies formed at the age of 2 years. So according to the father, the child would cry most of the times when passing urine, and there would always be dribbling of urine, and the child's trouser would remain wet most of the time. And also the child would complain, like he would cry most of the times when passing urine and would strain. And the father also complained of child having fever on and off over the past years, for which he was taken to different periphery doctors and would be given antibiotics and antipyretics, which would settle down his symptoms for a while, but then they would return again. So when the child presented to us on examination, he was vitally stable, abdomen was soft and non-tender, and there were bilateral ureterostomies, which could be seen in the picture, with rashes around, and the child was circumcised with bilateral descended testes and chest hair. So he did not have much of his past investigations, but whatever he had in the past lab workup, we could see that there were some creatinine levels going up to around 5.3. And he had positive urine cultures showing pseudomonas on 2 occasions. And also his ultrasound KUV, which was done on 4/10/2021, which showed bilateral echogenic kidneys with moderate hydronephroureter and left pyonephrosis. And then on 7/10/2021, his bilateral ureterostomies were formed. After which also he had undergone ultrasound KUVs. So on 25th/10/2021, His ultrasound showed the right mild hydronephroureter, left small sized kidney with moderate hydronephroureter and cortical thinning. And then on the February 2021, his ultrasound showed like right kidney measuring 8.8 centimeter with mild hydronephrosis and hydroureter, and left kidney measuring 4.6 centimeters showing moderate hydronephrosis with hydroureter and nephrostomy tube seen in situ. And left hydronephroureter was greater than the right one. So he also underwent a renal scan in March 2022, in which his right kidney showed a function of 92% and left kidney shows a function of 7%, and adequate functioning right kidney with outflow resistance, while hydronephrotic left kidney with poor function. So this patient came to us for definitive management, and so we did our workup, which included MCUG, lab workup, and ultrasound KUBs. So these are the MCUG scans. And this is the post-white film. And his lab workups, when he came to us, it showed the CBC showed an HB of 8.7 with a TLC count of 10.8 and platelet count of 382. And on discharge, his CBC was 12.1 and a TLC count of 11.6 and platelet count of 256. His ultrasound KUB was as follows. Left kidney was small, irregular in outline with cortical thinning. Upper pole hydronephrosis along with mild hydroureter was seen, and extrarenal pelvis was also seen. And right kidney showed mild hydronephrosis with minimal hydroureter. So when he was admitted under our care, he underwent cystoscopy plus PUV fulgation plus right ureterostomy closure and right BGS placement on 28th of July. And his findings were the meatus was normal, anterior urethra was normal, posterior urethra dilated and had valves at 5, 7, and 12 o'clock positions, which were fulgated with diathermy. Bladder was mildly trabeculated, right ureteric orifice was identified, and left paraureteral diverticulum, and left ureteric orifice was also identified, and ureter was dilated and edematous. So,
okay, basically, this is a 3-year-old child who lost his mother when he was born. The day he was born, his mother died because of the obstetric complications, and his father was the sole caretaker of this child, and probably because of that, he was noticed very late in the course of his first year of life, when father noticed that he's having on and off fever, he has trouble voiding, he remains wet throughout the day. When he started to have to be toilet trained at the age of 18 months, they didn't find that he's able to hold his urine, and whenever he voids with difficulty. So that's the reason he was taken to the hospital, which was in their city, and they found out that the child was in urosepsis and his creatinine was 5.3. At that time, without doing any cystoscopic examination or any other investigation, they got ahead with bilateral ureterostomies in this child, which made him better. But afterwards, no specific management plan was made. Therefore, they moved to another city and wanted to get the definitive treatment. When we got this child, we got the MCUG and found a dilated urethra. This was a case of PUV. We fulgurated the tube and we fulgurated the valve and closed the ureterostomy because there was no reflux on the right side when we performed the MCUG. We also found out that the side that we were closing is the solitary functioning. And afterwards, after closing of this ureterostomy, the child was voiding per urethra as well when the left ureterostomy was kept closed. And otherwise he was also leaking some amount of urine from the left ureterostomy side as a refluxing side. So that was kept as a safety valve in this patient. My question to the forum is, since we know that this child had a left patent ureterostomy and a poor functioning kidney, what time should this left side be operated in future?
Did we have a DMS? Did we have any kind of radioisotope scan for the function?
Yeah. Radioisotope scan. Dr. Heba, please show that slide. Radioisotope scan, Dr. Sharik, showed that the left kidney, where the ureterostomy is patent, is poor kidney.
Okay.
It's 7% function. This is a poor functioning kidney. It has to go anyway. This side of ureterostomy is still patent. It makes very little amount of urine. The child voids for urethra, but rest of the amount dribbles out from this ureterostomy. So this is kept as a safety valve. My question to the forum is, ideally the children with bilateral ureterostomy, once it is made, what time should we consider closing each of the ureterostomy sites?
When I think when you are planning some definitive procedure, or when we should then we should close the ureterostomy site. You have done your procedure, that's the PUV have been resected, his bladder was not that bad, so you have closed the ureterostomy. I think that was the fair not right time to close it. So left, you have just because of the solidly functioning kidney, you have left the left side open. It's still not functioning. So I think you are on the safe side.
Okay.
But there is a chance of having a neurogenic blood, some kind of neurogenic element in this patient also, because patient with posterior urethral valve may have some neurogenic element in the future.
Yes, that's the reason in cases where it is solitary functioning kidney, we should be very careful in closing the ureterostomy. Dr. Sarda, what's your opinion on this case? Can you share your thoughts?
Well, I think I basically think the same. The right side was already reimplanted, and follow that bladder, how the capacity is evolving, make sure there are no more problems, then I would connect the other ureter to the bladder. And although there's little function, but I'm sure it's producing a lot of water, I would still continue in reimplanting that ureter to the bladder.
Dr. Sarda, we didn't reimplant.
Oh, you
it
didn't?
Was just, no.
Okay, I would do reimplant. Okay, I'm sorry, I didn't get that. I would do reimplant one at a time. I would start from the left kidney, good functioning kidney, and make sure that it's planted properly with a JJ stand-in, and see how bladder is evolving. Then I would consider reimplanting the other. The matter of which one you start with would be controversial. I would prefer, if the left kidney is producing a lot of water, then reimplanting left kidney is also okay. But I would most probably start with the right kidney reimplantation. I would do it one at a time.
I think maybe in presentation that was not very clear. This child was born with PUV with probably bilateral VUJO. I think so, because when his bilateral ureterostomies were made a year ago, they did not get by MCUG before the surgery. They just made bilateral ureterostomy because the child had bilateral severe hydroureteronephrosis with a creatinine of 5.3 milligram. So the periphery hospital doctor made bilateral ureterostomy without getting an MCUG, assuming that this is a case of valve. And this child became better. When he came to us, we didn't reimplant. We got the MCUG, and there was no reflux on the right, towards the right ureterostomy side. So we assumed that maybe there was no reflux on that side from the very beginning, or if it was there, it has resolved, or maybe it is not evident right now. So we fulgurated the valve and closed the ureterostomy. While on the MCUG that we got, there was reflux on the left side, towards the left ureterostomy. So we didn't touch that side. We closed the right side. Now the question was when to proceed and how to proceed for the ultimate management before closing the left side, because the GFR is 80.
You're sure the bladder is functioning well and the kidney is not suffering from anything, the right kidney, that the ureterostomy is closed? Everything is okay with the right kidney?
Yes. After ureterostomy closure, everything is good with the right kidney. It's
Okay,
been a month now.
okay. I mean, why, there is no reason why you shouldn't reimplant or close the ureterostomy of the left kidney. I think you can do that now. If it's
Should
a
we
simple
close it or
closure
should we
of the
remove the kidney?
ureterostomy, it's easier. I thought, where is the ureterostomy? Is it near the kidney or is it the distal end?
No, towards the distal end. Dr. Hiba, can you please show the picture?
It was not visible in the picture though.
Okay. Hiba, can you please scroll up and show me the picture of the clinical exam? Yeah. This was when the patient came to us. This was the right ureterostomy. There was a lot of fungal rash, and we closed this side after.
That's a loop cutonostomy, right?
That's a loop ureterostomy. Yeah, it was closed. Now it is closed, and the right side is okay. As per ultrasound report and as per the symptom, the child is doing very good. He's voiding per urethra as well, and little amount of urine refluxes out through the left ureterostomy side.
Okay.
So should we close the left side? Should we remove the left kidney? Should we keep it for now and then, do some intervention after 6 months or a year?
I am mainly concerned about the bladder. I'd like to make the bladder function well. I don't mind much about the left kidney because it's already very poor. Having good flow of urine into the bladder is more important. This is the reason why I keep asking you how much urine that left kidney is producing, because although the function is very low, that there is a high chance that this kidney is still producing a lot of water. If there is enough water being produced from that kidney, I would still consider reimplanting it for the health of the bladder, because I suspect that eventually this child will go into transplantation. We want to have the best bladder function at the time of the renal transplantation. And one other option would have been, at the first place, would just to do one-sided cutonostomy, especially if there had been reflux. If you do one-sided loop cutonostomy, if there is reflux to that kidney, then actually you'll be creating a diversion, a cycling diversion. And this is much better than a cutonostomy. And it is almost as good as a bilateral cutonostomy, because since this is reflux to that ureter, any urine that comes into the bladder will be going up to that ureter and outside. This would act like a diversion. So rather than doing it bilateral, one could have done a unilateral loop cutonostomy if there is reflux to that side.
That's right. That's right. So, okay. So your question was whether this is making enough urine or not on the left side, which is it's still intact, the left ureterostomy. It's not making a good amount of urine, because when we examined the diaper of the patient, it wasn't wet on that side, on the left side. And as per information that we got from the father, is not making a lot of water.
Okay.
Yeah.
Maybe you could still keep it and see how the bladder is functioning, because eventually, if you need an augmentation, you never know what's going to be needed in the near future. If you need an augmentation, you can still use the left ureter to do the augment. If there is not urine being produced, I would consider doing an nephrectomy, but I would not do it now. Maybe wait a little more and see how the kidneys, how the bladder is functioning, how the bladder capacity is evolving. Maybe you can do you may need to do an augmentation using the ureter. Otherwise, that kidney will go anyway.
All right, thank you. So there are many questions I can see in the chat box. So one of the questions from Dr. Dr. Hiba, can you show the slide of MCUG? Because one of the question by Dr. Naveed Harwan, how does the bladder look like on MCUG? Okay, can you please magnify a little one of the image? So the urethra, posterior urethra looks bigger than the bladder. So because this was refluxing, a lot of urine was refluxing through the left ureterostomy, so the bladder could not be filled appropriately. But when we saw it on the cystoscopy, because we blocked both the ureterostomy, it was not that bad. One of the question from Dr. Zahra Kazmi is the left side is not functioning. Why not do a nephrouretrectomy? We just discussed that, Dr. Zahra. Dr. Mustafa Zafar asked, what are RFTs now before closing the ureterostomy? Before closing the ureterostomy, the RFT was the creatinine was 0.8 milligram per deciliter. It is still at this level after closing the ureterostomy. So ureterostomy closure on the right side did not lead to derangement in the renal function, did not lead to the re-emergence of hydronephrosis on that side, because when we closed the ureterostomy, there was no hydronephrosis on that before surgery, and after surgery, it is still not there. We will
Dr. Hina, I
confirm.
have a question.
Yes, Dr.
Can I ask Dr. Hina, Dr. Hina, you have a MCUG of a patient before doing fulguration. And secondly, if you pass the scope and you saw the bladder is good capacity, but it doesn't like this is not the surety that this bladder is a good functioning, because as you said that when you close the right side, the all urine is going to the left side. So this is a, I think this bladder is not a good functioning bladder. This is reflexing towards left side. So as you are talking about that, the creatinine is maintaining because you have a bladder is what the bad functioning of the bladder or the reflexing is going on the left side. So cycle is going on. So if you will close the left side or doing a nephrectomy, whatever you will do, so you will saw the results of the bad functioning after that. So it's better to first assess the bladder, right, for a couple of months or up to 6 months. Then you will decide. As Dr. Tagul said, I totally agree that this ureter will easily use for augmentation in future. So nephrectomy is not the right now the good option because there is no pyonephrosis and there is no fever and like this. So why we are going for nephrectomy? We have to keep the kidney and we have to assess further for the functioning of the bladder. I think this is a reflexing bladder, and the PU we have patients almost all have the bad bladder.
I agree with you totally, because maybe the renal function and hydronephrosis hasn't appeared yet because the left ureterostomy is acting as a safe valve, as a safety valve. I agree with you. So we are going to wait on this patient, and we'll see him in few months and assess how is the bladder, and we'll decide later on if he requires any implant, the augmentation. We may use the left dilated ureter in that case, but we'll take time on this patient, not going to rush in any case. And till that time, we keep an eye on the renal function of this patient and keep assessing the right side on the ultrasound. And of course, we'll keep an eye on the nephrological care provided by the nephrologist in terms of maintaining his blood pressures and electrolytes. All right. So I'm glad that we are finishing this meeting on time. And these were the three important cases. Really had a great time during discussion. I hope everybody of you had learned something very new, particularly in the presence of Dr. Tegbul and his great opinions on these cases. Thank you to all the presenters. This meeting is going to be continued next month, every Sunday, every first Sunday. of each month, we'll be doing case discussion. And I welcome all of you on this forum for presenting cases, because this is a very important forum where we learn a lot from our seniors. So thank you, everybody. I'm signing out. Have a great day. Bye-bye. Thank you, Dr. Tegul, for your presence. I appreciate that.
Thank you. It was a pleasure.
Take
Thank you,
care.
doctor. Thank you all. Thank you, Dr. Hina. Thank you.
Take care. Goodbye.